and abdominal distension was there, tender hepatomegaly was there, there's an epigastric tenderness as well, but there's no guarding or rigidity. And there's no splenomegaly as well. And there's a rash on the body which is blanchable. So this is the rash which was seen on the body. So with this history and examination findings, what is our differential diagnosis we can keep, and what are the workup to be planned? Fever followed by a febrile period of 24 hours with abdominal symptoms and rash. So what are the DDs? Postopioids. There are 60 slides, so if you don't answer fastly, we'll be delayed. No one want to answer? Kirtana? Hema?
So dengue, sir.
Dengue first likely like rashes, fever, afebrile period. And could be even we can think 8-year-old child like fever, pain, vomiting. We can think of any appendicitis, but there is no pain in the right ear also, but that could be a cause.
Okay. Any other DDs? The possibility of dengue is very high.
Intestine.
Is it recovery rash or it is a leaky rash? The rash what we are seeing in the picture is a recovery rash or is a leaky rash?
Leaky rash, sir.
So it's towards moving towards critical phase. So the rash in the recovery phase is different. It will be more likely the extremities with a pink red color, and mostly it's a leaky rash. And what other DDs apart from dengue? Okay, dengue is accepted. Any other DDs you want to keep here? It could be any viral illness. It's not alone dengue. It could be any viral hemorrhagic fever, any viral illness. Apart from that, bacterial infections, what we can keep is, so one of the close DD is scrub typhus. So the fever will be persistent. It can be seen. Rickets is the one DD, but was in the chart. They're the close DDs. Apart from the routine fevers, you need to rule out. So viral is highly etiology, dengue is the first thing, and apart from the rickets here, and even your enteric is a possibility. So keep all the DDs in watch and plan the workup based on that. So this is the investigations I want to send, and someone can interpret the results. And what is your diagnosis?
Hemo concentration is there, sir. Leukopenia, thrombocytopenia.
Yes.
Thrombocytopenia is there. Transaminases is elevated.
Good.
Dengue NS1 is positive, so acute phase is positive, while IgM, IgG is negative.
Okay.
Rest other negative, like infective panel is negative.
So what is you want to keep the DD now? DD
albumin on the lower side.
Yeah. So what is your diagnosis? The diagnosis.
Acute viral illness with thrombocytopenia, sir.
Okay. Why we cannot call it dengue right now? Because your dengue NS1 is positive. I don't mention it's a check. It's actually a rapid test. Dengue NS1 rapid test is positive. So can we call it a confirmed dengue, or you will have to call it as a viral illness with thrombocytopenia or viral hemorrhagic fever? So we cannot call it a confirmed dengue right now. So we need to call it a viral hemorrhagic fever, but we can label it as probable dengue, and we need to confirm it. And what are the differentiating features of scrub typhus from dengue? Which are close DDs, what we encountered in this season. So what are the differentiating? Can we differentiate clinically scrub typhus from dengue? Is it possible?
In scrub typhus, sometimes there could be an eschar, sir.
How many
And,
percent of
rash,
scrub typhus will have?
morbidly formed rash will be there in dengue.
Yes. SR will be seen how many percentage of scrub typhus? 10, 30, 50, 70. 4 options.
30, sir.
Yeah, it's only 30%. So if SR is there, high likely it is scrub typhus. Next.
Dengue, the child will be a little flushed on looking. We can appreciate that morbidly rash will be there in dengue, so which is blanchable.
Yes. Any other things? Always start with the history. Any differentiation when you want to do with 2 diseases, you start with the history, then examination, then investigations. So this is the way you have to flow. So starting with the history, what are the things you can differentiate from history?
If it's in dengue, there could be a viral illness, sir. So prodromal syndrome, like any cough, like in smaller children, there could be like prodromal illness, and biphasic fever will be there in dengue. And in scrub typhus, there will be like continuous high-grade fevers which lasting more than 5 days.
Yes, one is the continuous fever in scrub typhus. Second thing is dengue, there will be a fever and ephemeral period where the child will worsen. Good. So what is about fever? Second thing. In examination, something you are telling.
Capillary refilling time less than or equal to 2 seconds.
Okay. One is thinking about rash you told, that is one. Next. Any other examination findings, abdominal examination findings, which can be differentiate scrub typhus from dengue? Abdominal examination findings. Any observation findings? If it is there, it's highly towards typhus than dengue. Yeah, one is splenomegaly is the one thing. So we'll move on. So longer duration of fever presentation is the most important factor which points towards scrub typhus. As you told, it's SR and examination. Splenomegaly is the most important thing. Dengue will have less than 5% spleen, but in your scrub typhus can have more than 50%. And pneumonitis. So it is the most important thing which can differentiate scrub typhus from dengue. Dengue, you won't get pneumonitis in earlier disease. Only in the later stage, you can get effusions or you can get pulmonary edema rather than pneumonitis. And lymphadenopathy is a common finding in scrub typhus. And your investigation will show raised leukocyte count instead of leukopenia. And your PC will be at normal range even in the when child is sick and in shock. But in dengue, in shock, your PC will be very high. And there's an important study done in CMC Vellore about the differentiating features of dengue from scrub typhus. So they have taken these parameters like SpO2, hemoglobin, total count, SGOT, bilirubin, alert sensor, and total score. Among them, if you see the total count will be high in scrub typhus and it will be low in dengue. SGOT will be very high in dengue and less in scrub typhus. So depending on the parameters, if you have less than 13 score, that will favor the scrub typhus. More than 13 favors the dengue. So it's very important to differentiate dengue from scrub typhus because the entire treatment is different. So the scrub typhus can be easily treatable with your doxy and azithromycin and they recover dramatically. So dengue only supportive management. So don't miss scrub typhus when you suspect dengue, and there will be co-infections as well. So keep an eye open for them. And regarding confirmation of dengue, if you have a clinical picture suggestive of dengue, or you can have a rapid test positive for NS1 or IgM, you can label them as probable dengue. But to confirm dengue, you need all the following, any one of the following, like isolation of dengue virus, or demonstration of IgM antibody by ELISA, or NS1 by ELISA, or IgG seroconversion after 2 weeks, or detect the viral nucleic acid by PCR. So these are the things which is needed for confirm the dengue. So unless we confirm by these methods, you cannot put the final diagnosis of dengue. So the government will not accept that thing. So please make sure that when you are confirming dengue, you have done all these investigations, not the RTTs. And the timing is most important. So you need to time the test accordingly. So less than 5 days illness, you need to get the antigen test positive. And more than 5 days illness, you need to send for the IgM antibody. So this is the timing is important. PCR can be done at 10 mostly in the early stages. Less than 5. So what is the next line of management in this chain? So does you want to give IV fluids for this chain? And does this chain need antibiotics? And can we give platelet and FFP transmission because of thrombocytopenia and iron derange? And what are things you want to monitor in this chain? So these are the 4 important questions we need to ask ourselves when you see this kind of children. So how many of you think this chain needs IV fluids? Child, fever, poor oral intake, gastritis symptoms. You want to start or not want to start? If you want to start, how much you want to start? Half maintenance, full maintenance, 1.5 times maintenance. No one is managing dengue right now. Leave alone dengue. Any child admitted with these findings, what we will do normally? So some answered half maintenance, some answered 1.5 ml per kg per hour. Why 1.5 ml per kg per hour? The main problem in dengue is the capillary leak. So when we start capillary leak, the body will try to compensate for the losses. So when body is trying to compensate, just we need to give enough fluid what is leaking out. But body if not able to compensate and child is going to shock, then we have to manage the shock properly. So this child is not in the shock, so we need to just compensate what is the leaking. So because child is vitals are stable, just we need to titrate the fluid according to the need for the body. We don't need to give more or no need to give less. If you give less, also problem. So this child needs a maintenance fluid for the regular needs. Apart from that, you need to compensate for the leak. So we need to titrate the fluid based on the vitals. So we can safely start this chain in the maintenance, not less than maintenance, and based on the vitals, you can go up or down depending on what the chain needs. And second question is, does it need antibiotics? No, absolutely no. Dengue is a viral etiology, so we no need for antibiotics unless we have suspected co-infection. And whether I give platelet transfusion for this child, platelets are 25,000 and APT is 52. Can we start giving platelets and effect for this child at this point?
No, sir.
Good. So the next question comes, what is the indications for platelets and FFP in dengue? When you want to give?
There is any clinical signs of bleeding, sir?
Yeah, when is the signs of active bleeding, so we need to supplement it. So what is the first and foremost blood product you want to give when the child is having bleeding in dengue shock? You have blood RBCs, you have platelets, and you have FFP. So
blood.
Platelets, sir?
Okay, it is the blood. Blood is the first and foremost thing you need to give. So don't wait for like other illnesses where you want to replace platelets and FFP for bleeding. But in dengue, the entire pathophysiology is different in bleeding. The bleeding is because of shock, not because of coagulopathy. So if you start thinking of coagulopathy and correcting only coagulopathy, you will not correct the shock, and if shock is not corrected, the body will not able to maintain the hemostasis and the bleeding will not stop. So the first factor what you are going to give is PRBC or whole blood. So not platelets and FFP. And apart from the active bleeding, when you can give, so there's actually insufficient evidence that prophylactic platelet FFP transfusions will decrease the bleeding and decrease the mortality. So this evidence is very insufficient. And because of these transfusions, it can cause fluid overload. So to correct coagulopathy, we need large volumes of transfusion. So we cannot correct coagulopathy that much easily in dengue. So we need a lot of fluids which can cause fluid overload. And coming to indications, as you told, it's a massive bleeding or prolonged shock with bleeding not responding to red blood cell products. See, this is the most important thing you have to remember. When you have prolonged shock with bleeding, it is not responding to your RBC transfusions. Then only you have to move for platelet FFP transfusions. And if you're doing any central line procedure, central line catheterization or arterial catheterization, so we need a transfusion to prevent the bleeding from that side. And as a part of massive transfusion protocol. So when you're giving for PRBCs continuously for shock correction, this is bleeding, and you cross out the transfusion like a massive transfusion, then you need to give 1:1:1 ratio to replace the losses. And only platelets can be given prophylactically when you have platelet count less than 10,000. This is from the national guidelines. Even some units will wait till 5,000 also. So this depends on unit policy, but the national guidelines refer them. If you have less than 10,000 platelets, you can try prophylactic transfusion of platelets. Things to be monitored. One thing is to monitor vitals. And the vitals, the most important thing I want to be monitored is urine output. Whether you monitor heart rate, pulse volume, CRT, if BP is normal, the next vital, most important vital you have to monitor is urine output. The single most important vital which is to be monitored. And signs of fluid overload, like respiratory distress and abdominal distension. And I will monitor investigations regularly, that is PCV, platelets, and the lactate for when I'm managing shock patient. And everyone has to follow the strict input-output chart to see what is the balance and where we are heading towards fluid overload and how much is the output and how to titrate the fluids up or down. So what is the role of PCV? If you take a management of dengue, every dengue child will have at least 5 to 6 times PCV is done. PCV and platelets are the most common investigations to repeat in the dengue child. So why you are repeating PCV? So what is the role of PCV?
Hemo concentration, sir.
Okay, how it is going to help you in management? So this child PCV is 47. So what inference you got from this PCV?
Child needs fluid, sir.
Why?
Because of capillary leak, intravascular volume loss.
Okay. But child vitals are maintaining normally, right? When body is also already compensating for that PCV, then why you want to give fluids? Here, this child, we started fluids because child is not taking orally. If the same child is taking orally, I will not give fluids for this child. So PCV alone will not give any inference for you people. That's what I'm telling. Don't take PCV single value. The PCV has to be interpreted with clinical status along with the serial monitoring. So single value of PCV alone have any value here. So you need to combine it with hemodynamic status of the child and you need to monitor serial PCVs. So as you told, it's guide the rate of fluid and also type of fluid. The PCV will tell how much rate of fluid to be given along with the hemodynamic status and what type of fluid to be given. This is the most important thing. That's why you need to monitor PCV serially. So can anyone interpret these two scenarios? So one, child is in shock with high PCV. Second scenario is child is in shock with low PCV.
Child in shock with low PCV is that some internal hemorrhage or something is happening, sir.
Good.
That's why PCV has dropped.
Okay. So high PCV is capillary leak. So everyone knows this is the two common situations we are going to encounter in dengue shock.
Sir, one doubt, why we are doing lactate in this case? Like, Like PCV platelet, okay. Lactate, what influence are making? Sir?
I don't understand your question.
No, like investigations to be repeated every day along with PCV and platelets. Why we have to do lactate, sir? Like,
For this child not needed. I put it as for routine child. If any child comes in shock, we'll monitor lactate. So to
okay, okay.
of the lactate test. No, not for this child. This is
Okay,
routine
sir.
child.
Oh, thank you.
So this child clinical status is stable and PCV is in 47, so not in shock. So we don't need to worry much. So we'll just give the maintenance fluid and see how the child is moving ahead. So these are the two important slides we need to interpret. So high or increasing PCV. So child is in shock. So it is a capillary leak. You need to give fluids. If the child is stable, you don't need to increase the fluids. Even if the PCV is rising, your vitals are stable, don't go up on the fluid. This is the commonest mistake what we'll do, because we've seen the pricing trend of PCV. Even though child is very stable, active, we keep on increasing the fluid. So when his body is trying to compensate for that PCV and that leak, so we don't need to worry about that leak. So we need just to monitor the vitals. I'm telling not to monitor the vitals, just leave the child. No, you should monitor the vitals, and every hour you need to modify your fluid plan. At this hour, the PCV is high, but child is stable, so you watch the child. Next hour, the child may, because of the leak, child may decompensate as well. So then you need to give more fluids. So at that moment, you need to increase the fluid rate. So don't anticipate the child might go into shock. So next hour, so I will give fluids this hour. No, that is not the management in dengue. So you cannot anticipate how the child is going to move, how the body is going to compensate. So try to manage the child as and now where the child status is. So normal and low PCV, child is in shock, you have suspect hemorrhage, and you need to give for blood transfusion. And the child is stable with a normal or low PCV, you have to think the child is going to recovery phase, and you have to tap the fluids faster. So this is the important thing we need to understand in managing the dengue. So combine PCV with hemodynamic status. PCV alone will not have any role. When you combine with the hemodynamic status only, you can manage the child. So these are 4 common scenarios you will face in any management of dengue child. And so these are 2 important things. Without the classical teaching is the drop in PCV with good urine output is a welcome sign, the child is recovering. Then drop in PCV with a drop in urine output, it indicates a bleeding. So you need to remember these 2 things. So what are the principles of fluid therapy in dengue? We all know that IV rehydration is the single most important intervention that will save lives, but if you have to provide it timely and appropriate. And there's a 2 parts in fluid therapy. One is the initial fluid boluses to reverse the shock, followed by titrated fluid volumes to match the ongoing losses. So not like septic shock, we keep on repeating fluid boluses. Here we'll just give a fluid bolus to make sure the shock is corrected. Shock is corrected means just you're maintaining the vitals at that moment. And from next hour onwards, we need to titrate the fluid volumes to match the ongoing leaks. So how we'll know how much leak is going to happen? By monitoring the vitals. And this is the most important line we all need to remember in managing of dengue. That the main aim is here is you have to give the just enough intravenous fluid to restore the minimally acceptable circulating volume, not the normal circulating volume. So we all know the dengue will the critical phase will be only for 48 hours, and when the 48 hours is over, the child will enter recovery phase. So once you give more fluids in critical phase, in the recovery phase, they will end up in fluid overload, pulmonary edema. So that's why we should not overload the child in the critical phase by chasing the vitals. So we need to maintain the vitals, perfusion for vital organs, not for the skin and muscles. The main, our aim is to perfuse the vital organs by minimal circulating volume, not the normal circulating volume. Never aim for the normal circulating volume, just to maintain the minimal acceptable circulating volume. So how you will know that vital organs are getting perfusion? That is only by monitoring urine output. If your kidney is able to make 0.5 ml per kg per hour of urine output, that means your all other vital organs are perfusing well. That is enough for them. If your kidney is not making urine output of 0.5 ml per kg per hour, that means your other organs also not getting perfusion. So we need to step up on the therapy. And second thing is you should avoid fluid overload. So this is the most important statement when you managing a dengue child. We need to remember this one. So don't over rush the fluids to maintain the normal vitals. So targets of fluid resuscitation is classical teaching, decreasing tachycardia, normal BP, normal pulse volume, warm and pink extremity, CRT 3 seconds. Especially this third statement is very tricky. We'll chase this statement and we'll run behind this statement for giving more fluids. We'll definitely land up in fluid overload. So in my experience in the last 7 to 8 years, I never run behind pulse volume and extremities. I even accept 5 seconds of CRT, low normal pulse volumes, and cold peripheries in critical phase. If my BP is normal and my urine output is more than 0.5 ml per kg per hour, and my lactate is maintaining at the same range, not increasing. If lactate is maintaining at the same range and urine output is more than 0.5 ml per kg per hour, that means your vital organs are perfusing well, but your skin and muscle is not perfusing well. I am not bothered about skin, muscles, and gut, because I know in another couple of days, jail might recover and fluid will restore back. So that's why you will not chase them back. So never aim for normal pulse volume, warm peripheries, and normal CRT. Just accept the borderline CRTs, borderline pulse volumes if your urine output is more than 0.5 and your lactate is not increasing. So this is the most important thing. I'm going to achieve decreasing tachycardia, not normal heart rate, decreasing tachycardia. I will achieve normal BP and stable consciousness. If I will achieve these three things with urine output of more than 0.5 ml per kg per hour, I will stop the fluid there. Stop means I will not increase further. I'll just stop, hold on the fluid there, and Chelis continue to be stable like that. I will come down on the fluid based on the PCB. I hope I'm clear on this. People don't get confusion here, just because it's a textbook teaching is like you have to achieve everything normal. But if you're trying for everything normal, you can land up in the fluid overload. So my suggestion is not to achieve, go for full correction. You accept the low volume normal, like low normal pulses, cold peripheries, and 4 to 5 seconds CRT when urine output is more than 0.5 ml per kg per hour. So this time we have started this chair on 3 ml per kg of fluid, and after 2 hours, this is these vitals. This heart rate is jumped, BP dropped. So pulse volumes are just like this, and urine output is 0.4 ml per kg per hour. PCB was jumped from 47 to 50. So what is his current status now?
Child is in shock, sir.
What shock? Severity. When you have to tell shock, you have to tell the severity of shock. This is an 8-year-old child. 8-year-old child. So what shock? Is compensated or hypotensive shock? Come on, this is basic.
Like
What is the
borderline,
system?
like system is 86, the child is having like 84.
Okay, so it is
Hypotension shock, so like 84.
exactly, it's hypotensive shock. According to Paul's guidelines, when your BP is less than your target systolic BP, that is hypotension. It's hypotensive shock. Correct. So except dengue, this holds good for any shock. But in dengue, because the pathophysiology is entirely different, so the classification is slightly different. So even in compensated shock, they can be in having hypotension. So this is the adult target. So even in children, if they have SBP low also. So in dengue, we'll put them in compensated shock only. We won't label them as hypotensive shock. And the classification in dengue is also compensated and profound shock, not hypotensive shock. So in profound shock, you have signs of shock with undetectable BP. You have severe hypotension. So that's the main difference between compensated shock in dengue and the profound shock in dengue. So even with hypotension in dengue, we will label them as compensated shock. But if BP is very unrecordable, like very low BPs, then we label them as profound shock. So this child is in which shock? Compensated or profound shock? So this child is in compensated shock. So how will you manage this child now? compensated shock? Come on, how you manage? Any shock compensated? So this is the algorithm which is given by the WHO national guidelines. So this child is in the compensated shock. So we need to start this child on IV crystalloid. So you can start at 10 ml per kg per hour, and if you feel you want to go up also, you can go. So but my practice is to start only with 10 ml per kg per hour, and if needed, we can continue one more bolus next hour. So this child we started on 10 ml per kg per hour NS bolus because he is in the compensated shock. So this child received total 20 ml per kg NS for the next 2 hours. So these are the vitals after 2 hours. So you can see a dramatic improvement in BP. Pulses are like better, CRT is improving, peripheral is becoming warm, unit output is good, PC is coming down. So what do you want to do now? You given 2 boluses and your vitals are improving. And so what do you want to do now?
Continue the same. Accept.
Continue the same. Why you want to continue the same?
We have required urine output, sir, and so vital organ perfusion is good, so we can continue whatever we are on.
Okay. Why you don't want to come down? Because already you given 2 boluses and your vitals are normal, PCVs came down. Is there any harm in coming down? No, I'm asking, is there any harm in coming down? So this is the most common dilemma we'll face as child is maintaining, just no child improved, whether I want to mess with the child. So there is a commonest dilemma. At some point of time, everyone knows that we need to come down on the fluid. So question yourself, why not this hour? You cannot keep on giving this 10 ml per kg per hour for next 48 hours. At some point, we know that we need to come down on the fluid. So when you are watching the child closely, try to come down every hour. Try to win. If the child vitals are maintaining persistently for 1 to 2 hours, you know that I can come down. So see, like I am standing at the bedside, so I am going to monitor this child. So I will try to intervene with the fluid. Don't play safe games here. It's not like safe games. You think it's safe, but later on child can come become a fluid overloaded with pulmonary demand and land up on the ventilator also. That will be unsafe for the child. So right now your duty, you can be a playing safe game by maintaining child vitals. But after 48 hours, child can land up on the ventilator. So don't think about safe things. I'm doing safe for the child by not allowing the child to go into further shock. It's not like that. So you need to keep titrating the fluid to match the leak. If the leak is like 10 ml per kg per hour leak, you need to give 10 ml per kg per hour. If you feel that leak may be improving, you come down and see next hour. If your vitals are maintaining, that means you didn't correct. If your vitals are not maintaining, again you go back. You go back to 10 ml per kg per hour. Again 1 to 2 hours. Then again come down. Watch. Improving. Continue and come down. Worsening. Go back. So this is the way you have to manage the dengue child. Not by keeping the 10 ml per kg per hour a number of hours. So please make a point here that don't stand on the same fluid for 2 to 3 hours. So you need to maintain and monitor and modify your fluid regimen. So don't stand on the single fluid, single rate for a number of hours. So the most important point I want to stress here. So this child, as child is improving and maintaining vitals well, I will try to come it down. I will not stay there. So this is algorithm as well. That is the same thing. If you have improvement with the crystalloid improvement, yes. So you need to give 10 to 10 ml per kg over 1 to 2 hours. So I have already given 2 hours of crystalloid for 10 ml per kg per hour. So I will come down to 7 ml per kg per hour. And if child is still maintaining vitals very nicely, I will come down further. So there is no harm in decreasing the fluid rate to 7 ml per kg per hour in this situation, as the child is maintaining vitals and already given 2 hours of fluid bolus. So the same child, we drop the fluid to 7 ml per kg and we give it for 2 hours. Then we drop it to 5 ml. As child is maintaining vitals very well, we drop it to 5 and give it for 2 hours. Then this is the vitals now. So your pulse volume is normal, BP is maintaining, periphery already become warm, urine output is good, but your PCV went up from 46 to 47. So what you want to do now?
We can still decrease the fluid, sir, because urine output is adequate, so perfusion is good. So 3 ml per kg.
Very good. So this is what I needed. So don't see only PCV. So only PCV will not going to tell you anything. So take PCV along with the hemodynamic status. So here for the last 4 hours, we are coming down on the fluid from 7 to 5 and still child is maintaining hemodynamics. Maybe at 5, the child, the leak may be slightly higher, but the body is compensating well. When the body is compensating well, we no need to increase the fluid rate. Here you can continue the same 5, or as you told, you can easily come down. So here it's tricky. Someone feels that yes, a leak is increasing. Whether I want to come down, I will watch for 1 more hour. Okay, fine. You can watch for 1 more hour or 2 hours. But definitely after 2 hours, if the still PCV is high, increasing to 48 also, if vitals are maintaining stable, you need to come down on the fluid. I am going to make it 3 ml per kg despite the rising PCV. So you want safe, you can wait for another 2 hours. But if you are at the bedside, you are going to monitor this child, you can come down to 3. That's what my point here. So I will come down the fluid rate and I will stop the fluid as further the child improves. The main funda is the body is compensating very well for ongoing plasma leak. So we don't need to give more fluids because we know under 48 hours child recover and he will take back the liquid fluid into the intravascular volume. Okay, till now we are seeing the improvement scenario. So we'll slightly change the scenario. So after initial 10 to ml per kg bolus, this is the vitals now. Your heart rate improved with the fluid bolus, your BP is maintaining borderline, and your pulse volume is okay, low, still lower side, CRT is still 5 seconds, peripherals are cold, urine output is still low, and your PCV is staying still there. So you given 20 ml per kg bolus, and so you already seen the vitals. So what you want to do now? Someone is raising the hands. Any questions?
Yes, sir. While decreasing from 5 ml to 3 ml, below weight 20 kgs, usually maintenance will come more than 3 ml, no, sir?
Yes.
So for suppose if it is 14 to 15 kg child,
Yes.
3 ml will come only 45, but maintenance will come to 52 ml.
Yes.
So which one do we prefer, sir, in that case?
Definitely I will prefer only ml. I will not bother about maintenance because I already given what is more than maintenance for this child already. 10 ml per kg fluid, 20 ml per kg fluid, 7 ml, 5 ml, like that. I already given more than maintenance for the child.
Okay.
But it might not be the intravascular volume, it has leaked out. But
Okay.
here we are not bothering about maintenance, we are bothering about vitals. If you feel that the child is losing more fluid out, leak and with the maintenance losses also.
Okay.
What will happen the next? If you're giving less fluid, what will happen to the child?
Sorry,
There is
sir.
loss by maintenance, loss by leak, and you're giving less fluid. What will happen?
I didn't get you, sir. Not
You're
able
giving
to
3
hear.
ml per kg per fluid,
Okay, sir.
and child is losing by maintenance losses. The maintenance
Okay.
losses is your skin, your respiratory, your urine,
Okay.
and your dengue causing leak.
Okay, sir.
But you are giving only 3 ml per kg per hour. So if you feel child is losing more, either by the maintenance losses or by the leak losses, so what will happen in the next hour?
Then again, the PCV will start increasing. So we need to hike the fluid.
No, don't see the PCV and hike the fluid. That's what I'm telling.
PCV and also along with that urine output and the vitals,
Exactly.
everything we'll
Exactly.
see, sir.
Just to concentrate on urine output, PCV and urine output.
Okay,
If
sir.
urine output is dropped again, that urine output is 0.6 ml per kg per hour, I make the fluid 3 ml per kg per hour.
Okay, sir.
Next hour I got only 0.3 ml per kg per hour.
Okay.
But vitals are stable. Vitals are stable, but you need to drop it. So what I have to do now?
Then we need to hide the fluids because the
Go back to
urine
5 ml
output
per
has
kg per hour. That's all.
Okay. Okay, sir. Okay.
So like that, you need to titrate. You don't
Okay.
stand at a single fluid. That's what I'm telling. Don't stand at a single fluid. Every hour, you need to titrate the fluid up and down.
Okay. So no, while titrating only after 5 ml, when we want to come to 3, we need not see whether 3 is more or maintenance is more for that child.
Oh,
We can directly come down to 3. That's what I want.
Definitely.
Okay. Okay, sir.
Because you are going to closely monitor this child, definitely you can come.
Okay. Okay. Okay, sir. Thank you.
So this child, what I have to do now? So this child is still in the shock, compensated shock, and input is still less. We already given 20 ml per kg NS. And what do you want to do now? Come on. Someone answered albumin, colloids, good. So when you tried crystalloids and you not got that much response, the next thing what we can try is colloids. So this is the algorithm. So where you are standing now? We are standing here. So we are given crystalloid for 2 hours and there is no much improvement. We have to check the PCV and PCV is still in the high range. So your PCV is 50. So we are going to give colloid for this child. So I will start 10 ml per kg per hour colloid bolus for this child. So coming to colloids, what is the role of colloids in dengue? And how many types of colloids we all know? Is there any disadvantages for colloids? When you give colloids, what are the things you have to monitor? And among all the colloids, what is the best colloid?
Usually, normal fluids there will be leaks. Colloids, like the molecules will be larger, so there won't be leak through the intravascular volume. Like capillary leak won't be there. That's why we can give colloids.
You are partly correct. Your point is correctly valid. So you are telling that colloids have large molecules, they will not leak. No, that is wrong. But you are partly correct. The rate of leak will be less. Even with albumin, they leak. Your damage to the intima layer is very extensive that even the albumin will leak. So don't think that colloids will not leak. If that like that, there will be a dramatic improvement in colloids and all the guidelines will change to start colloids at the first instance itself. And there will be a huge change in mortality difference. So, but all the studies will tell there is no change in mortality difference in colloids. The reason is that they will leak less, but if they leak, they will drag the fluid along with them. So colloids are osmotic agents, so they will drag the fluid and they will cause compartment syndromes. They will stay there in the third spaces. They will not come back also. So whatever colloids leaked out, they will have more time to come back to the intravascular volume. So in that way, they can cause more problems for you also. So that's why I think that colloids are not that safe when you are trying to treat in dengue. So crystalloids, you know, they leak rapidly, so you need to give more fluids. Colloids, they leak slowly, but if they leak more, they can cause more problems as well. So you need to balance. So the balance is very important here. So the one important factor in using colloids is theoretically they overcome the shock more quickly because you are giving more oncotic fluid, so they can increase the shock, correct the shock rapidly, and by preventing the more leak, so they can decrease the fluid overload risk. So what is the need? You can decrease your fluid volumes, giving fluid volumes, and they say profound hypotension. So you can try to give colloid rather than crystalloid because they can restore the BP urgently, rapidly. So that's all. That's the only advantage of colloids, but they are not going to change any of the hospital stay terms or mortality. There's no clear advantage in terms of mortality and hospital stay. So they can decrease the fluid need. They can correct the shock rapidly, and if your BP is very low, you can try colloids. This is the only thing they can do in the fluid management, but they will not change your hospital course and mortality. That is the disadvantage. So you have natural colloids like human albumin and artificial colloids like gelatin, dextran, and starch. So these are different molecules available in the market. So depending on the disadvantages and advantages, we'll try to choose what is our need in the dengue. So you have starch 6%, 10%, volumen, and the gelafusion is kind of gelatin and dextrans, and your 5% albumin and 20% albumin. 20% albumin we won't use in dengue in critical phase. Remember that in any shock, it's 5% albumin is the choice. And when you're treating for hypoalbuminism like nephrotic syndromes, you need to give 20% albumin. So not in the dengue. But the biggest disadvantages are they can impair your coagulation. Already you know in dengue they have a coagulation problem. So this dextrans and this starch can impair your coagulation further, and your gelatin will have allergic reactions, and they can damage the osmotic renal injury. They can cause osmotic renal injury, and the most important thing is they can leak. They can once they leak, they can cause compartment issues. So be careful when you're giving colloids as well. They're not that safe as you think. And there's an upper limit for starch and dextrans. Your upper limit for starch is 50 ml per kg and dextrans is 30 ml per kg. You cannot go beyond this. So this is one limitation for this. It can be overcome by your gelatins. Gelatin, there's no upper limit. You can go up how much you can give. And there's no upper limit on 5% albumin also. So this is the most important thing. I think you have to remember this point. And these are the disadvantages. Everything will affect the coagulation except your gelatin. And gelatin has the highest allergy potential. And dextrans will cause renal failure in hypovolemic patients. So my choice, when your patient is affordable, the choice is 5% albumin, and next is choice is gelatin, next is starch, and last is dextran. So this is what my choice is. And you can consult others also what is their own preferences. So my preferences, the patient is all affordable. I will try to research the child with more of 5% albumin and gelatin. Till now, I not use starch and dextran. I completely avoid them because I have safer alternative of gelatin. So this is the status of the child after 20 ml per kg colloid bolus. So we have seen the improvement in the vitals. Urinary output is improved, PCV is dropped out. So what we want to do next? So you given like say gelatin. I given gelatin for 2 hours, and this is the vitals right now. And what I want to do next?
Can we change to crystalloid, sir?
Can we change to? Narendra, mute cheyva. Yeah, can we change to?
Crystalloid.
Crystalloid, sir.
Yeah, very good one. Any other answer? Someone is answering whole blood. I know why you want to give blood at this moment. Any reason for giving whole blood at this moment? As child is improving. No. When vitals are stable, even PCV is dropping, you should not think. When PCV is dropping, vitals are improving, that means child is improving. Your vitals are dropping and PCV is dropping, then only to think of DD. Here the vitals are dramatically improving. The heart rate came down, BP improved, the urinary output from 0.3 improved to 0.8, the CRT is coming down and PCV is coming down, that means you are compensating the leak well with your fluids. So there is no point of giving blood in this situation. You may be correct when your urinary output is still 0.3 ml per kg per hour and PCV is 45. You might try by giving blood. But when urinary output is more than 0.5 and your PCV is coming down, that means your child is improving. When child is improving, you need to change your management. So you can rightly say you can change the crystalloid or you can come down on the colloid as well. So this is the guidelines. So what you can do is when child is improved, you can come down to colloid of 7 ml per kg per hour. You can give it for 1 to 2 hours and then can switch over to crystalloid. So like this also you can do, or you can straight away switch over from 10 ml per kg to 10 ml per kg per crystalloid. Either way, you are right. There's no harm from changing from 10 also. But to be safe, you can come down to 7 on colloid and change to 10 on 7 on crystalloid. So that is where we can do. And you can come down like previous scenario, you can come down with child is stable. But our hospital, we won't do this, we won't follow this protocol. So we will try to continue colloid with crystalloid combination. Say if you are giving 7 ml per kg per fluid, so what I will do is I will put 4 ml per kg per crystalloid and 3 ml per kg per gelatin. That is colloid. so that I'm making sure that I can cut down the fluid rate. And if you can question me like that. So when you're doing combination, why cannot give only gelatin? Why you want to give add combination crystallite? The answer is already I told. The colloids also can leak out. If I'm giving only colloid, they can cause later compartment symptoms. So I will try to balance it. Whether I want to give 3 ml per kg per hour colloid with 4 ml per kg per crystallite, or vice versa. 4 colloid and 3 crystallite based on my vitals. I start with 3 ml per kg per hour colloid and 4 ml per kg per hour crystallite. Next hour, my unit is dropping. So what I will do, I will not increase the rate. I will change the combination. I will change the colloid to 4 and crystallite to 3. Then I will try. If the chain is maintaining vitals, I will hold it there. And after 1 to 2 hours, I will cut down. Like 0.5, 0.5, I will cut down. So 3.5 colloid, 2.5 crystallite. Or 3 colloid, 3 crystallite. So you can try various combinations depending on your patient status. But you need to try modifying something. Don't sit on the same thing. The most important thing is you keep on modifying your fluid regimen. 1 to 2 hours, still is stable, come down. And becoming unstable, your input is decreasing, go back, modify your therapy, come down. Your input is dropping, go back, come down, go back, come down, go back. So you don't know when this chain is going to improve. Whether the chain is going to improve in next 12 hours or 24 hours or 48 hours. Till that time, you have to try your fluid rates. You have to modify fluid rates. Don't sit on the same fluid rate for at least more than 4 hours. If you're sitting on the fluid rate for more than 4 hours, means you're not doing a good job. So you need to try coming down, going back, coming down, going back, but make sure that you are at the bedside. You're monitoring the child. If you're not monitoring the child, how much fluid rate you are going to give, child is going to worsen or child can land up in the fluid overload. If you think that I'm going to go home, so I don't want to take the risk, so I keep continuing 7 ml per kg per hour because child is maintaining well. But tomorrow morning you come back and see child in ventilator. So that way fluid is a double-edged sword. If you don't give fluid, child can worsen. If you give more fluid, child can worsen in other way. So try to make a family policy that you are at the bedside titrating the fluid. The most important intervention, what to be done for a dengue child is the doctor sitting at the bedside and modifying the fluid rate. That's the most important thing that can save the number of lives. So that is the previous scenario. So here also child improved, so we come down on the fluid. And this is the another alternate scenario where we given 20 ml per kg of colloid bolus. So we given crystallite for 2 hours. Then we switched over to colloid for 2 hours. And further, after 2 hours, child had abdominal pain and distension. And these are the vitals now. There's a drop in BP, unit output is still low, and there's a dramatic fall in your PCV. So what is the interpretation? What do you want to do next year? We have to move. Our time is moving up.
Think of internal bleeding, sir.
Exactly. Very good. So you have unstable vitals with a drop in PCV. So the next thing you have to think is internal bleeding. So what do you want to do now?
Fresh blood, sir.
Fresh blood. So don't think that PCV is 40. That means hemoglobin is 13. All shock guidelines tells that the target of HB is 10. Here the patient is maintaining 13. Why I want to give blood? This is the commonest mistake we'll do in our practice of managing dengue. So never think like that. The PCV is 40 is at the background of hemo concentration. If you properly adjusted the hemo concentration, the PCV can drop to 30, 28 also. So you don't want to that extent to give the colloids, and by the time child will worsen and child will not recover also. So if you have to catch the child in this point itself. So if the PCV is dropping with unstable vitals, don't let the child sink further. Arrange for a fresh blood and transfuse as early as possible. I hope I'm clear on this. So don't think of seeing PCV of 40 and someone is asking blood transfusion. Why they're giving blood transfusion for PCV of 40? This is nonsense or this is waste. So I have seen many of my seniors told me the same thing. PCV is 40, you should not transfuse. It's not like that. So PCV is 40 is a background of hemo concentration and vitals are unstable. Dropping of PCV from 50 to 40 is a very unwelcome sign. So you need to go for blood transfusion in this scenario. So these are the guidelines. You can see here, there is no improvement after your colloid bolus. So you check the PCV. If PCV is decreased, that means you suspect occult bleed or overt bleed. Here overt bleed is not there, so it's occult bleed. So you need to go for urgent blood transfusion. But if it's not suspecting occult bleed also, so what made we suspect occult bleed here? This point, abdominal pain and distension. So any child with severe abdominal pain which is worsening with a fluid resuscitation, think of internal abdominal bleeding. So because pain can be there from admission, but if it is worsening with fluid resuscitation, that means it is bleed. Think of that with dropping PCV. So that made me think of occult bleed here. So I need to go for blood transfusion here. So I can try 10 ml per kg whole blood or 5 ml per kg PRBC for 1 hour. And I had to prefer fresh blood less than 5 days. Don't give transfusion of PRBC over 4 hours. So that is a wrong concept. So many of us, we still be doing that thing, but we need to modify that thing. So here we are studying shock. Shock, whatever fluid you give, it is like a bolus. It is not like regular transfusions. Here you need to give, if you have whole blood, give it over 10 ml per kg per hour. Or if you have PRBC, give it over 5 ml per kg per hour. Then you reassess again. After 1 hour, you reassess. What is the PCV? What is the hemodynamics? If PCV is still low, you can continue blood further. If PCV is increased and your shock is still there, you can switch over to colloid. If child is improved and your PCV is improving, you can switch over to colloid as well. So, what is the reason for fresh blood? Why you need only fresh blood here, not the old blood? Can anyone answer why we need only fresh blood in dengue shock? Okay, we'll move on. What is the indication of bleeding? If you have significant overt bleeding, definitely you have to give blood transfusion. Also, when you suspect concealed bleeding, how to suspect? There's a drop in HCT without any clinical improvement. This is the most important scenario we're going to face. So if you don't have any other investigation, ABGs we don't have, just to follow this. There's no clinical improvement or much improvement, and PCV is falling. Suspect bleeding and give the transfusion. And you have severe metabolic acidosis and rising lactate, despite your fluid replacement, think of bleeding. Then also you need to give the transfusion. And rate I already told, it is not like 4 hours, you need to give rapidly. And the reason for fresh blood is, in the whole blood, there is a deficiency of 2,3-DPG. If it is deficient, your oxyhemoglobin curve will shift to left, and it will not leave the oxygen to go to tissues, and it can cause first tissue hypoxia. So that's why we need to try to get the fresh blood, not the whole blood. If you give whole blood, then the child cannot improve. So because you are not delivering oxygen to the tissues. So make a habit that in dengue transfusion, you have to get the fresh blood, at least less than 5 days. So these are the vitals after 10 ml per kg PRBC transfusion over 2 hours. The vitals are improved, your urine output is improved, your PC is improved. What do you have to do next? Faster. What do you want to do next? Given 10 ml per kg PRBC, child improved. What do you want to do next? You want to continue blood or you want to switch over to something?
Switch over to crystalloids, sir.
Yeah, it can be, but the guidelines say switch over to colloid. So see here, you have improvement. Yes, you need to go for colloid. You give colloid for 1 hour. Don't shift directly to crystalloid. What they're recommending is from blood, you have an intermediate of colloid. If colloid and colloids you're improving, then switch over to crystalloid, like this previous scenario. This is the only difference in the guidelines. So blood, colloid followed by crystalloid. So course the next 4 hours, child hemodynamics got better. We wean it to 5 ml per kg per hour. But now child developed tachypnea and there is increasing effusions. But child was maintaining saturations and room air. So these are the vitals of this child. So output better, PCV is decreasing, pulse volume becoming normal, CRT is becoming normal, peripherals are warm. But child developed tachypnea and there is effusions. And still we are on 5 ml per kg per hour fluid. So with this scenario, how many of you want to try Lasix? So we are weaning the child to 5 ml per kg per hour, and currently child developed tachypnea and effusions. Your vitals are very well. So here, anyone want to try Lasix to decrease distress? If yes, What is the fonda? Anyone want to try Lasix? Come on, it should be interactive. You have to move on. Say yes or no. You want to try or not? Don't want to try? Someone answered no. Why?
No, sir.
Why don't want to try? You want the child to land upon ventilator? Child is developing tachypnea, efficiencies are increasing. So you want to put the child on NIV or ventilator by giving by don't starting Lasix? If you answer this question, you have understood this concept very well. Yeah, someone is answered. You should drop the fluid first, not the Lasix. 100% true. So don't worry about respiratory status. You can save the child by putting the child on NIV or ventilator or oxygen. But if you make the child drop in the vitals again, this time child may not improve also. So this child in shock, improving nicely, and by giving Lasix, if you cause further intravascular volume status low, child can go back into shock again. So you are worrying about respiratory, but what I am worried more is cardiovascular here. So if you maintain cardiovascular, you can support respiratory by, you want to try NIV, you want to put on a ventilator, that's fine. But if you tilt the balance, if you tilt the hemodynamics again, we are giving Lasix, you may not even get the child out of the shock again next time. So don't think that we need to give Lasix at this point of view. The main aim here is you need to drop the fluid first. Still 5 ml per kg is very high. So you need to come down on the fluids. Then you want to try Lasix when child is stable on the very minimal fluid for quite some time. So my policy is try to wean the fluid is a minimal of 1 ml per kg per hour. Then even on 1 ml per kg per hour, the child is maintaining hemodynamics very well and your PCV is not much increasing at a minimum of 6 to 12 hours. If you want to be very safe, keep it 12 hours. But if you don't have any facility for NIV or ventilation, you can at least maintain a target of 6 hours. That is your hospital scenario. So my hospital, I have a very facility for NIV and ventilator. So I can safely wait for 12 hours if the PCV is maintaining there, not increasing much. And hemodynamics is maintaining very well on the 1 ml per kg per hour. And I will start Lasix only after that. And I don't want to give Lasix bolus. I am going to start only Lasix infusion at a very minimal rate, 0.05 to 0.1 mg per kg per hour. That is what I am going to start. Never try to give Lasix bolus because you don't know what is the sensitivity of that child for the Lasix. One child can pass only 100 ml, one child can pass 500 ml, one child can pass 1 liter. If the child can pass 1 liter with 1 mg per kg Lasix, you are out. You are going to crash the child and you are going to restart the child again. The entire last 6 hours, 8 hours of management, you are going to restart again. So that's why never try Lasix bolus. You can give slow infusion starting at 0.05 to 0.1 mg per kg per hour and see the response. You know what is improving, vitals are maintaining. You can go up, you can step and increase 0.1, 0.2, 0.3 till you get the desired negative balance by watching the vitals closely. But if you give a bolus of Lasix, you cannot titrate the vitals. You cannot make the vitals in your control. So don't ever try to give bolus dose of Lasix in dengue. That is what my suggestion here. And so we trap the fluids minimal. We start on Lasix infusion. Next 24 hours we have negative balance and we efficiently cure and child improved. We shifted child to ward. So this is how we able to manage this child out of the shock. Any doubts till now? Anyone want to comment here? The management? If no doubts, I'll move on. So scenario 2, where we get the late referrals. If the child came very early like this, we can easily salvage the child. But if the child come late, what are the complications we are going to encounter? So we have seen a 12-year-old old obese child, produced fever for 2 days, abdominal pain, decreased oral intake, admitted in local hospital for 24 hours, managed as dengue, NSL positive, had severe thrombocytopenia, given transfusion, status IV fluids. Finally, child developed worsening respiratory distress and altered sensorium. So for this reason, child was referred to our hospital. So you have seen a classical dengue with thrombocytopenia, managed with fluids and transfusions, worsening distress and altered sensorium. This is what child was referred to us. At ER, air was maintainable. You can see tachypnea, SpO2 is 86%, air entry was decreased, marked retractions, heart rate was high, BP is very low, pulses are steady, CRT is prolonged 6 seconds, peripherals is cold, sensorium was 9/15, pupils are reacting, RBC, GRBC is low, and abdomen is grossly distant and tense, and this is diffuse tenderness over the abdomen. So this is the status child referred to us. So what is your physiological status and how you will manage this child next? So what is the physiological status of this child? Pulse physiological status. Come on. The profound shock, respiratory wise. Respiratory wise, child is in.
Child is in recovery phase. There is a fluid shift. We have overtreated with IV fluids.
Respiratory
That
distress.
has increased the respiratory distress. That has worsened respiratory distress. And second thing, the child is having altered sensoria.
Yeah. See the vitals and tell.
So we should think of.
This is not recovery phase. Child is having profound shock with respiratory failure. That is what our physical status at this moment. So what are the cause of respiratory failure in dengue? So it could be your effusions causing compartment syndromes, like intra-abdominal ascites causing compartment syndrome, pleural effusions, or fluid overload causing pulmonary edema, or your dengue myocarditis causing pulmonary edema. These are the main cause for respiratory failure in dengue. Think of this when you have this child. I'm going to manage my clearing secretions because altered sensorium is there. I'll supplement O2 and I will go for early NIV because child is having significant distress. Because profound shock, I'm going to view 20 ml per kg NS bolus by push and pull. As hypoglycemia is there, I'm going to give dextrose. A child has an altered sensorium. It could be due to shock also, but I don't want to take a risk. It could be dengue encephalopathy also. So I will try to manage the child neuro protective measures. I give 3% NS bolus as well. I'll send the investigations. So with these measures, SaO2 improved to 95, and we given another bolus also for this child. So what do you want to do next? So these are the investigations. We have seen total leukopenia, low platelets, your PCV is 40, significant elevated liver enzymes, significant derange coagulopathy, NSO is positive, others are negative, CRP is 6.7, severe metabolic acidosis, lactate was 13, ferritin was high. So what is your interpretation with these results? So this is a classical case of dengue. And what is your interpretation of PCV? Child is in shock with PCV is 40. What is the interpretation? Profound shock with PCV 40. Profound shock with PCV 40. What do you want to do now?
Blood.
Yeah, good. So this is a state of bleeding.
Any internal hemorrhage.
And child is in acute liver failure as well. Whereas what is prognostic deranged, INR is more than 2.3. So you can give vitamin K as well here and repeat the INR again. So now we move on to what are the causes of excessive fluid overload. Because everyone is thinking this child is in recovery phase because of over resuscitation, but it's not recovery phase. This child is in the critical phase only. Because child is unstable vitals. Only when you think recovery phase, when child is in stable vitals. So one thing is excessive and too rapid IV fluids in the initial phases. And incorrect use of hypotonic electrolytes. So apart from the NS and DNS in the infants, you cannot use other fluids. Half DNS is strictly prohibited in dengue management. You can try RL, but even RL is hypotonic, a little bit hypotonic side. 134 is the your sodium. So I still prefer NS and DNS rather than RL, and no half DNS. And inappropriate usage of large volumes of IV fluids without recognizing severe bleeding. This is the calmest mistake we'll do. This is what should have happened in the referral hospital. So they might not be thinking of internal bleeding, and they should have given more fluids, thinking of shock, and child should have become fluid overloaded without correcting the shock. That's why I'm going to stress this point again. Think of internal bleeding at the earliest. When your PCV is still dropping, not below like 30, 28, even in the 40, 45 range, your vitals are not improving and PCV is dropping, think of occult bleeding and give the blood. Don't delay the blood. If you delay the blood, you're going to land up in refractory shock. And inappropriate transmission of components. So you think of bleeding and you're not giving PRBC, you're given other things, FRP platelets, and you can land up in fluid overload. And you are not stopping the fluid, you are continuing the same fluid for a number of hours. So these are the common things, which is fluid overload. And other conditions like your ischemic heart disease, congenital heart disease, and sepsis, and you have lung problems. These are the other comorbid conditions which can cause fluid overload. So think of all of them when you have child with fluid overload. So after 1 hour, child is still worsening, distress increasing, we decided to ventilate. So what are the precautions we have taken for this child before ventilating? So this is a physiological unstable situation, physiological difficult airway. So what do you want to do now here? So there is a shock, there is a metabolic acidosis, there is a severe distress. So we have 3 conditions: hypoxia, shock, and acidosis. So what do you want to do now when intubating this child? Precautions?
Correct.
Step by step. Yeah. So first thing is respiratory wise, you have pre-oxygenate and you can give like bag and mask ventilation, matching the rate with the patient rate, and sedate them and paralyze and give the fluid bolus. And you can even try low dose vasopressor to maintain the BP in this child and bicarb bolus. So these are the things we need to do when you are ventilating this child. So child successfully intubated, these are the settings. Your PEEP kept at 9, kept at 100%, but your PIP is very high, 57. And child has still unstable hemodynamics, abdominal girth is increased, child started bleeding, this is the X-ray. So these are the vitals. So high ventilator settings, these are the X-ray, abdominal girth is increasing, child is bleeding from nose and mouth. This is the commonest scenario when you encounter a child in late phase, and his still vitals are like this. Little better, but you not put still 0.3 and PCV is still 38. So what are the problems now? What do you want to do now?
There could be higher ventilator settings. We should think of any pulmonary hemorrhage also in this scenario. So.
Correct. You can think of.
Okay.
But there's no ET bleeds. Child is bleeding only from nose and mouth.
So we can give like transfusions like PRBC, platelet, FFP back to back.
Good. You can give. Exactly. Next. What is the most important thing which
BP is low.
Most important things which can stop bleeding in dengue, apart from your PRBC transfusion and correcting the shock and other blood component transfusion? What is the most important thing you have to do? How many transfusions you give? Without these things, you cannot stop bleeding. Use your common sense. If any child is bleeding from nose, what are you going to do? Or any child bleeding from skin, what are you going to do?
Sudden, like we can
Compression.
patches.
So you need to go for local methods. Someone raised hand. Please ask question. Ramanjanaya Naik, any question?
No, sir. No, sir.
Yeah. Okay. So exactly. So you need to go for local methods. Apart from your systemic methods, you need to go for local methods in this stage. So problems in this is persistent shock, active bleeding, very high ventilator pressures, acute liver failure. So management I'm going to do is for shock management, I'm going to give emergency PRBC and whole blood transfusion. I'm going to do nasal packing for the active bleeding. I can try platelet and FFP transfusion also. And the most important thing is antifibrinolytics. Majority of people will forget this. Keep on transfusing. Try tranexamic acid with amylate, like this, some things also they have shown. So improvement. Vitamin K also you can try. Definitely they can work. But the most important thing is correct the shock by PRBC transfusion and do the nasal packing. And for liver failure, you can try endosteric system apart from the liver measures. So can we give furosemide because of your lung is very bad, your high pressures? Can we given now to decrease the lung pressures? Yes or no? Again,
No,
same
sir.
question. No. Even if child is going to die, I'm not going to give Lasix in this situation. Because anyway, child is going to die because of shock. So measures to control bleeding. The most important measure to control bleeding is not platelets and FFP. It is blood. Don't forget of transfusion. PRBC transfusion, whole blood transfusion. Never give FFP transfusion, platelet transfusion before PRBC transfusion. The first priority is PRBC, not platelets and FFP. So I am stressing this again because I'm going to see the same scenario and people will jump and give platelet before PRBC transfusion. That's not going to help. So don't forget local measures. Don't allow the child bleed. You can compress, it can stop bleeding even in coagulopathy. And avoid edge tube insertion. This is the most common reason for bleeding in dengue child. Post intubation is someone will try edge tube insertion. So they will cause bleeding. Local trauma. And can try transexamic. These are the things we can use. So this is the simple ones. This is the some molecules where they can drag the water, they can enlarge. So just insert this is the initial one. You can insert into the nose like this, and with the local moisture, they can swell up like this, and they can compress the tissue. It is easily available. It's a Medocell or Evolon patch. This is easily available in the market. You can try this. And for the posterior nasal packing, this is the only anti-nasal packing. The posterior nasal packing, we can insert the Foley's bulb. You can put the Foley's bulb like this. You can inflate the Foley's with the saline and the posterior nasopharyngeal wall and do the anterior packing with the Evolon patches. So you can compress the posterior wall, the posterior plexus, and anterior wall, little plexus. So both plexus will be compressed. So this is the child. What we done, this is the packing we'll do. The Foley's will be hanging there, and we do the anti-nasal packing like this. So I'm telling it will help. It will dramatically stop the bleeding. You can see rapid rise in hematocrit as well. So try this. Try this local measures to stop bleeding. So with the above measures, bleeding is controlled, but shock is not getting corrected and is worsening. Now the PCV is 45. SpO2 is falling. Even on ventilator, high safety, your SpO2 is falling. Yeah.
Sir, when will we remove posterior nasal packing, sir? How can we know
which one?
whether it is by posterior nasal packing by Foley's or by inserting Foley's inflammation? When we will remove, sir, that?
Anything once you feel that the child PCB is maintaining very well and your coagulopathy is reasonably corrected and the child is out of shock, mainly on 24 hours. We'll at least 24 hours, and after 24 hours, I'll release and see.
Okay, sir.
So what do you want to do next? SpO2 is falling, PCB is okay. We have improved PCB by giving blood transfusion, but shock is still not corrected. Abdomen is getting tense, and what to do next? So this is a scenario of refractory shock. We have done everything, we corrected everything, but still is still refractory shock. So what are the cause of refractory shock? The most important thing is your inadequate plasma replacement, inadequate replacement of leak. And second thing is occult bleeding. So here we are not addressing this. We have given fluids, we have given blood, but still we are not improving. So we need to look for A, B, C, HS. A is abdominal compartment syndrome. B is, can anyone, if you know this, you understand dengue very well. One more A is also there. Abdominal compartment syndrome, one more A. Come on, this can be seen in any shock. Any refractory shock, I suspect all these things.
Acidosis.
Yeah, good.
Acidosis, sir.
B. Uncontrolled bleeding. So C is cardiac dysfunction. It could be due to sepsis or it could be dengue myocarditis. And most importantly, your metabolic things: hypocalcemia, hypothermia, and hypoglycemia. Don't forget these things. Please think about any shock, not on dengue, any shock. Hypothermia is the most important one, which can worsen the shock rapidly, and it can worsen the acidosis. It is a vicious cycle. Hypothermia, acidosis, and shock is a vicious cycle. If you don't correct hypothermia, your acidosis and shock will not get corrected. So think of all these things. And last thing is sepsis. Hospital-acquired sepsis is the most common entity which can cause worsening shock. So think of all these things. So in this child, you need to think of all these things. So we started channel HFOV because SpO2 is low. We started HFOV. Next option we have HFOV. And suspecting abdominal compartment syndrome, as the abdomen is very tense, we have done paracentesis. And we remove 300 ml of fluid. When you remove 300 ml of fluid, your vitals can go unstable. So keep the boluses ready, start the bolus and do the tapping. So here we give crystalloid colloid boluses. And this hypocalcemia, we corrected it and we did echo. Echo revealed LV dysfunction. So it's a dengue myocarditis. So we started channel adrenaline. So with this measure, shock improved, mental statics decreased, bleeding control, abdomen became soft. Gradually, we decreased the fluids. Input improved. After 24 hours, we are thinking that child is out of critical phase, and we start the furosemide infusion and we remove excess fluid. Sensory was normalized and we extubate child after 48 hours. So this is the scenario. If we can manage the child like this, child can come out even after this much bleeding and refractory shock. So never lose hope in dengue. They can recover. If you modify your management according to the child need, definitely child will recover if the child present little early. Not in very refractory shock where child already landed up in vasoplegic shock. You cannot make the child come back from there. So try to refer the child early when you are not able to manage the shock. That's the main funda here. So coming to the role of vasopressor therapy in dengue. So your vasopressor can increase the BP but will not improve the perfusion. So they're waste. Unless you have internal intravascular volume, your vasopressors will not going to help much in dengue. So try to improve intravascular volume. So the paradox is they can worsen tissue hypoxia and increase lactic acidosis. So if your heart rate is increasing along with the BP, that means your vasopressors are not working. Don't try them. Give more fluid. And indications is a temporary measure like intubation. During intubation, we'll anticipate fall in BP, so we can try starting vasopressor at that point of time. And if we have cardiogenic shock due to myocarditis, you can do even ischemia. Profound hypotension can cause myocardial stunning. There also you can try adrenaline. And you have added septic shock. You can try vasopressor like noradrenaline. And in refractory shock, not responding to fluid and blood, this is late presented, so you can try vasopressors. But before starting vasopressors, you have to make sure that you have filled the tank fully. If you are an underfilled tank, your vasopressor will not work. If tank is empty, they will not work. So you need to fill the tank first. So coming to abdominal compartment syndrome, we can read it. Abdominal compartment pressure more than 20 is the abdominal compartment. Because of massive ascites in a short time, they can easily land up in abdominal compartment syndrome. If you feel a tense abdomen, your fingers are not insinuating well, try to tap the abdomen. They can worsen the shock, it will not improve. So how to tap it? You can do a controlled tap. You can put a cannula, kind of IV set, and you can control the drainage. The initial rate is 4 to 6 ml per kg initially, followed by 2 to 3 ml per kg over 1 hour. So this is the control rate. So don't drain fastly. If you drain fastly, child can become worsen the shock and worsen, and child can bleed inside also. So these are two important things you need to remember. Don't drain the abdominal fluid rapidly at the go. So control only for 6 ml per kg initially, followed by 2 to 3 ml per kg next hour. So this is the way we can check the bladder pressure. So we'll measure the bladder pressure by connecting it to the transducer. If it's anything more than 12, so we need to try to tap it. Even abdomen is not tense. We won't wait till the abdomen becomes tense. We'll just connect the bladder to the ABP transducer, arterial BP transducer. We'll connect it to the arterial transducer. We'll measure the bladder pressure. This is the Foley's catheter. We'll connect this thing. If anything more than 12 bladder pressure, we need to tap the ascites. Control it, we have to tap. And this is the technique we'll follow. We'll put a cannula, a pink or gray, green cannula. We connect a 3-way IV set, and we can control it. Once we got the fluid down, we'll close this. Once you close this, we can control the drainage. So you can try, it is easier. So you can put a cannula. This is an arterial catheter. Even you can try central line catheter. Central venous catheter, you can put into the abdomen. That's really more easier and more less traumatic for the patient. So these are the techniques you can use for controlling control paracentesis. So this child improved, but after 4 days, child developed fever spikes again. Initially, there is no fever for 2 days, and after 4 days of febrile period, child had fever spikes, and child had again shock. But this time, child pulses are bounding. It's not like hypovolemic. It's bounding pulses. Peripheries are warm, and this is hepatosplenomegaly. Initially, there is no splenomegaly. Now, child developed splenomegaly. So what the did is now 4 days febrile, and again new onset fever spikes, and distributive shock, and with splenomegaly, new onset splenomegaly. Come on, ladies. Yeah, one thing is HLH. Second thing is in the hospital worsening later.
Hospital acquired
infection. Think of that.
Co-infection.
Exactly. So these are the 3 Ds I will keep: co-infection, hospital acquired infection, HLH. So these are the investigations I will do. So I have done the PCV/HB is 8.8. All other initially platelet count improved to 80,000, and again it is dropped from 80, dropped to 23,000. Your CRP is high. Liver enzymes came down to 12 hundreds, and again they went back. I checked with dengue, malaria, streptococcus again because of co-infection. Now this IgM is positive. It's confirmed with dengue only. No other infection is there. And now I did the ferritin. Ferritin was 86,000. So fibrinogen was low. Triglycerides are high. So blood culture came sterile. So now what is your diagnosis? So we have 3 DDs. We done the workup, and this is the workup.
HLH.
Exactly. So this is HLH. So when to suspect HLH? Any persistence of fever beyond 7 days or recurrence of fever, elevating transaminase. Initial elevation is because of shock. Once you control shock, it will normalize. But again, this elevation, then you have to think of HLH. Progressive cytopenias, new organ dysfunction, any AKA or ALF, hepatosplenomegaly. Initially, it's no hepatosplenomegaly. Now splenomegaly is there. Hepatomegaly is common in dengue, but splenomegaly is very rare. And not responding to the conventional management of dengue. So think of HLH. So this is the criteria: fever, splenomegaly, cytopenias, hypofibrinogenemia, hypertriglyceridemia, hyperferritinemia, and bone marrow showing hemophagocytes. So this child satisfies the criteria of HLH. So we're going to treat this child. The treatment is steroids and intravenous immunoglobulin. So not like classical HLH. This is secondary HLH. So no need to start etoposide. So we can straight away start steroids. If you want to start Dexter, you can start or methylprednisolone. So these are the doses. You need to give for 5 days, and you have to step on it slowly. And IVIG 2 gram per kg. You can give for over 5 days or 2 days. That's your choice. So these are the first line therapy: corticosteroids and intravenous immunoglobulin. Refractory, you have to start etoposide. So that child improved with this treatment and sent home. So last scenario. So this is the scenario: 6-year-old child, 4 days fever, 2 days no fever, body pains, admitted to local hospital, given IV fluids, dengue was positive, PCV was 45 initial, and stable hemodynamics throughout the stay. And now the child is referred because worsening distress. No point of time, child had unstable hemodynamics. Hemodynamics very stable throughout the stay. And given IV fluids, and the PCV was initially 45. Now child was having respiratory distress. So now child was referred to us. This is the situation. Heart rate was like normal side, BP was normal, CRT is okay, pulse volume normal, child is needing oxygen, urinary output is good, but PCV is 33. From 45 PCV, your PCV is 33. Bilateral effusions are there, no bleeding. So what is the phase now? We are treating critical phase or recovery phase. So where are we now?
Recovery phase.
Exactly. So vitals are stable, that is drop in PCV is recovery phase. Vitals unstable, dropping PCV is critical phase, and it's bleeding. Just remember this point. So what do you want to do now?
Classic, start classic.
First you stop fluids, start diuretics.
Okay.
Give the respiratory support as needed. So this is the common scenarios we'll face in dengue management. I hope I am clear on the scenarios. So we'll move on to the next take home messages. So don't neglect dengue, thinking of only COVID. So by assessment and investigations, we can easily differentiate acute febrile illness into the diagnosis. And co-infections are common. Try to figure out whether you are dealing with a co-infection when you are already diagnosed with one infection. And fluid therapy is the only therapy which can save a dengue child. No other therapy, no other inotrope is not going to save any dengue child. You can add them up. If the child has myocarditis or sepsis, you can add them up. But if you don't give fluid appropriately, it can kill the child. If you give more fluid, if you give less fluid, it can kill the child. So you have to give fluid timely and appropriately. And you have to modify the fluid accordingly. Colloids and crystalloids, you have to titrate depending on your need. And think of occult bleeding. If you have persistent shock, especially in the setting of drop in PCV, think of occult bleeding. Don't wait for the PCV to drop below 30. Telling that I need to transfuse only blood when HB is 10, less than 10. So that is not a scenario in dengue. So even if PCV is falling to 40, from 45 it's falling to 40 and shock is persistent, think of occult bleeding and give blood transfusion. And actually look for compartment syndromes. This is the most important thing we'll forget. We'll keep on giving blood transfusions, PRBC fluids and inotropes, but we'll forget abdominal compartment syndrome. Even with little tense societies, they can have abdominal compartment syndrome. Don't wait for that very tense abdomen. The child is abdomen is very tense. That means you have visited the at least 4 to 5 hours of abdominal compartment syndrome. So try non-invasive ventilation in preference to invasive ventilation because invasive ventilation can decrease the preload on the heart. So first priority is non-invasive ventilation. And reserve the platelet FFP transfusion for sick children, significant bleeding even after PRBC transfusion. The first priority is PRBC, not the FFP and platelets. And try to give local measures of control bleeding. Don't keep only focus on the blood transfusions. And don't attempt NG tube in dengue children. So dengue can present variedly. It can present as encephalitis. This is expanded dengue syndrome. Go and read about expanded dengue syndrome. So there are a number of presentations, pancreatitis, encephalitis. So keep an eye open for it. So the last slide, early identification of shock, appropriate and timely fluid therapy, and appropriate type of fluid is more important. And early referral, if you're not able to manage the child, will save a lot of children. Thank you. So you can ask doubts. I hope I'm very clear on dengue management. Any doubts, or we can conclude the session?
For maintenance fluid, we have to put only NS or DNS, both.
That depends on your child status. If a bigger child, no ALF, even you can try NS. But if you are very worrying that child might land up in hypoglycemia, you can give DNS. But if you're giving very high rates, like 10 ml per kg per hour of fluid, I will never try DNS. I can put half NS and half as a DNS, like that. So the most important is to monitor the RBS. I forgot to tell, if your RBS is very high because of your DNS, it can cause false elevation of urine output. Child is in shock, but because of hyperglycemia, your urine output will be high. So you think a child is out of shock. So there's a false thing. Never forget to check RBS when your urine output is improving. So shock child, urine output is improving. Think about check out GRBS, especially when your shock is not improving also. Vitals are unstable, urine output is improving. Think of hyperglycemia as well. Your choice. You want to give half as NS, half as DNS, that's your choice. But in fact, I will try to give more of DNS. Rather than NS, I will go for DNS because they will end up in hypoglycemia easily. And ALF child. No role for steroids in dengue shock. Only in dengue HLS you can use steroids. Do never try steroids in dengue shock because it can cause gastric bleeds, gastritis and bleeds. So we have to try only in HLH only. Any doubts? You can ask in the group also, WhatsApp group also. Any doubts? I will conclude this meeting.